and welcome you all, and also welcome Michelle, Werner, who is a registered pulmonary function test person and respiratory guru at Froedtert in Madison.
Milwaukee.
Okay, good. That's what I thought. And then I got nervous. So thank you so much for being here. And I'm just going to turn it over to you and let me make you a co-host so that you can share your screen if you want to. And we will go from there. Thanks so much, Michelle, for being here.
Yeah. All right. So my name is Michelle Werner, like she said. I am a respiratory therapist at Froedtert in Milwaukee. So I've been a respiratory therapist for about 12 years, and I spent the first 5 years working inpatient respiratory. And now I've been at the pulmonary function lab there, so more outpatient, for the last 7 or 8 years. So I've been doing breathing tests, and I do stress tests and things like that. And I was asked to join the ALS clinic there about 3 years ago at the beginning of 2020. So I've been not there in the working with ALS too long, but it's been 3 years, and I've learned a lot along the way. So I do have a presentation I'm going to share, and I have given this a couple times before to our ALS, the Milwaukee area ALS groups and everything, about the respiratory care with ALS, different devices and supportive equipment and things like that. So I'm not very good at this. I'm gonna share my screen. Let me find my presentation here. Hold on.
We are not a very judgmental audience.
Okay. I usually have my husband do all this because I don't know how. Okay, but I'm gonna find. Yes, hold on. I need to find my. Okay, here we go. Okay, can you see this? Okay. Okay. I'm gonna move. I had to have my husband set me up on here because I just don't usually do stuff like this. Okay, so respiratory care with ALS is the title of it. And the main things I'm going to talk about today are the respiratory issues that can come up with having ALS, the pulmonary function testing that we usually do, different kind of breathing exercises that can help, and then lastly, supportive equipment that can help as well. So if you do have questions along the way, you can ask them, because sometimes it's easier to remember while I'm on a topic, but also I'll do questions at the end too. So whatever works. So first I'm going to talk about the respiratory issues. I got my notes too. Respiratory issues with ALS. So ALS can cause weakness in many muscles, including those. Hold on, I can't see my whole thing. I'm going to move. Sorry. I'm going to move our pictures.
That's okay. Yeah. Do you know how to do that?
I don't know if I do.
If you go to the top and do view.
Okay.
And like gallery maybe, and then if your slides and the pictures, you can there's a line down and you can kind of move them so you can see both. That was not at all helpful, I think. I don't know.
That's okay. Hold on. I'm going to go back. Oh, I know I'm just making this worse. Okay. I got my notes. It's okay.
Okay.
Okay. So, like I was saying, ALS causes weakness in many muscles, including those that do involve your breathing. So managing the symptoms of those issues is one of the major components of care with ALS. And a lot of those symptoms can be shortness of breath, trouble sleeping, like laying down, or just in general, even if you are upright sleeping, just getting more short of breath with sleeping, and then a weakened cough as well, which I will talk about all those in more detail and the equipment that can help them. So going on to pulmonary function testing. So this is my main thing that I do at work. So I do pulmonary function testing on a whole bunch of different kinds of diseases up in our lab. But I do go down to the ALS clinic once a week at Froedtert, and I do pulmonary function testing there for people that come in. So the main test that we do there is spirometry. It measures the airflow, so the rate of the airflow and how much air is exhaled. So the volume and the speed that it is exhaled when you exhale really quickly, so hard and quick. And the measurement that we get from that testing that we look at the most with ALS is the FVC, which is the forced vital capacity. That the vital capacity is kind of the air that you are able to out all in a full way. So the whole get your basically your lung capacity that way. It's the most important breathing measurement, like I said, for measuring for trending the ALS breathing. It measures the volume of air exhaled with a with a full exhalation when you exhale really forcefully. The number, so we get a number in liters of air. So how many liters of air you blew out the whole way. And so that's going to be different for everybody. So like my lung capacity is way different than like my husband who's over 6 feet tall. So his liter of air is going to be hopefully a lot more than is it how many liters you were able to out. And
Michelle, you just broke up. Hang on a second.
Oh, sorry.
We got as far as your husband who's 6 feet tall. Do you mind
Okay.
starting over from there? For some, I don't know what happened. Sorry.
That's okay. Sorry. It might, I hope it's not me. Oh my God. Can you hear me?
Now it's fine.
Okay.
Yep.
So like his lung capacity, he's over 6 feet tall. So his lung capacity is most likely going to be higher than mine just because he is a lot bigger than I am. And so what the system does is it takes how much air that you are blowing out the whole way forcefully, and it compares it to what somebody like you should be able to blow out. So that's like your reference value. So it's somebody, it takes your age into height, your gender, your race, and your height are the four main that it is set off of. And so everybody has a unique set of reference values for them based off of those items. And it compares what you did to what they think that you should do. And it gives everybody a percentage. And that's how they normalize kind of everybody is based off the percentage, since the liters of air is going to be so different across the board and you have no way of knowing if that's good or not. It compares it against the set of reference values and it gives you a percentage, and that's what we look at. So make sure I'm not moving on. So the percentage we trend, at least in our clinic. So the person will come into our clinic on average about every 3 months, sometimes 2, sometimes up to 6 if they're doing really well. And I do this test with them every time they come in, and we trend that number to make sure that it's staying the same, or if it is going down, what we can do with that. So that is the main breathing test that we do with in the ALS clinic. It gives them the best idea of how your muscles are still helping your lungs get that air in and out. There are a couple other tests that we can do up in, like I can't do them in the ALS clinic with my portable device, but we can do them up in the pulmonary function lab with our bigger equipment. Sometimes the doctors need to see a little bit more. Or if you're trying to qualify for certain equipment that, let's say your spirometry number would not qualify you for, there is other tests that we can do that could possibly qualify you for some more supportive equipment if you feel like you need it, if your doctor feels like you need it, but your spirometry number won't qualify you for that. And that's mainly based off of insurance, but there is ways that we can kind of get around it if needed. So these other tests that we can do, that they look at. The first one is called your MIP and your MEP. So it's your maximum inspiratory pressure and then your maximum expiratory pressure. And that is a test that measures, you kind of breathe against a pressure, and it tells us how well your muscles are kind of really helping you breathe against that pressure. So the maximum inspiratory pressure, you kind of, on the mouthpiece, you suck in air really forcefully, but it's against a pressure. And so it's like they're trying to take the air away from you, but you're trying to pull it in. And we can see it gives us a percentage again, and we can see how well your muscles are helping you really get that air in and out against these pressures. So they can use, those numbers are typically lower than spirometry. So they'll use those numbers sometimes when, if they want to get a better idea of how your muscles are working with your lungs, or if you're trying to qualify for some equipment. There's also a test where we do spirometry again. It's called spirometry upright versus supine. And that we do a normal spirometry measurement. So the one that I was just talking about on the other slide, where you blow out really hard and fast, we get your forced vital capacity. But then we do that same maneuver laying down flat. So we have a recliner that we bring in, and or some people will use their wheelchair if it does recline, and we lay you down almost flat like you're sleeping, and we do the spirometry maneuver again, and we see how it is supposed to be lower. So we see how much lower it goes. And they look for a certain amount lower to say that you do really have trouble breathing while you're laying down. So we do that upright and then laying down, and that can usually qualify you for some equipment too, if the spirometry itself doesn't, or if they want to see, if the doctor wants to see how low your breathing really is laying, it just gives them a better idea of how they can help you. Okay. Oh, I guess I didn't realize I had that on my slide. So this is just what I just explained. So the MIP measures the MIP and the MEP. So the maximum inspiratory pressure, maximum expiratory pressure, measures the strength of the muscles that are used during inspiration and exhalation. So at the MIP, you exhale completely, and then you're going to inhale really quickly against a kind of a pressure that's pulling the air away from you. And then with the MEP, the maximum expiratory pressure is kind of the opposite. You're going to inhale completely, and then you're going to quickly and forcefully exhale that air, but the machine kind of cuts it off and gives you a pressure back at you, and you got to blow through that pressure. It is kind of a hard test. I've done it myself, but it gets done what you need to do. So,
and I think most of the folks here have had to do that.
Yes. And I guess my next one is the upright versus supine. So also what I said, you do a normal spirometry maneuver first, and then we lay you down on your back, and we do that again. It detects, it actually looks at the diaphragm that way. So the diaphragm is the big muscle at the bottom that helps you breathe in and out. And we see when you do that test laying down, it kind of tells us how well your diaphragm is kicking in to help you breathe when you're laying flat. So the supine forced vital capacity can reveal some abnormalities in the diaphragm function that the normal forced vital capacity maneuver won't, which will, like I said, if you're trying to qualify for equipment, it'll allow the provider to initiate the non-invasive ventilation quicker or sooner to help you. Okay. So some of the complications of the testing, and I see this a lot even in our clinic. So the loss of facial muscle strength makes it difficult to form a tight seal around that mouthpiece. So I don't know if anybody's ever had that, but so we have a mouthpiece that you put in your mouth, and you have to make a good seal around it with your lips, so no air leaks out the side. And if the muscles have a hard time making that seal, it will give false low readings because the air is also coming out around the mouthpiece, and we're not measuring that. In our clinic, we have two different kinds of mouthpieces. So if someone can't make a tight seal around our normal one, we do have another one that we put on that covers a little more of the sides of the mouth, so you don't have to use all your muscle to make that seal. And that works well. It is not, we still have a lot though that that cannot do that. So that is a complication of the testing. Sometimes we're not able just to get numbers. If a person just really can't get their mouth to work well around the mouthpiece. I don't really have much information on this because I'm just starting, but I'm looking into using masks with that maneuver, like a mask that would cover your nose and your mouth, instead of having a mouthpiece go in your mouth. There are some studies on it with ALS that are somewhat promising, but I cannot make those decisions myself. So I have to wait for the providers to kind of say that I can. So it is hopefully something that in the future that I will be able to use once in a while if we really need a breathing test from someone and they cannot do it.
I can put it in the chair. If that works for you, Mom.
Okay. So one of the other complications of testing is called glottic closure. And the glottis is kind of like a flap back at the end of the airway that kind of, you don't really have control over it. It just kind of opens and closes on its own when it needs to. But if your muscles aren't working as well as they should back there, your body just doesn't control it as well. So sometimes when you're doing the spirometry maneuver, your glottis, the flap will just close and it cuts off the air that's coming out. And it kind of stops the measurement prematurely. So like it says here, it's closing of the vocal cords during exhalation, causing airflow to suddenly stop before the lungs have been completely emptied. And it kind of, I know that it's happening with our test. It makes a certain noise that's kind of like almost like a low moan. So you're blowing out all your air really fast and then nothing's coming out anymore. And it kind of sounds like a low moan that's coming from with the testing. And so I know that that's happening. And I know that your numbers would be higher if that glottis was still open. So I always let the provider know and we document that and everything, but it is not something that is usually that you can help because usually your glottis just opens and closes when it needs to on its own, nothing that you can do to control that. But if the muscles aren't really doing what they should, it just is not controlling it anymore. So it could, like it says, your forced vital capacity could be falsely reduced from that. But I know when it's happening and we always make note of that. Okay, so that is it for the pulmonary function testing. We do a whole lot more pulmonary function tests up in our clinic, but those are the main ones that we do with ALS to look at the muscle strength when you're breathing. So I'm going to go on now into breathing exercises. I just have a couple, but things that can kind of help you kind of expand your lungs a little bit, use your lungs a little more every day. Nothing too crazy, but just a couple things that could help. So the first one is called breath stacking. And so when I always teach this in our clinic when someone new comes in, also someone who's been here a while, I reiterate it just in case. But it's a series of breaths that you take on top of each other without exhaling. And it's meant to interrupt a cycle of poor airway maintenance. So if you're getting short of breath, it also works well with if you're just have anxiety, which is making you short of breath, things like that. You can kind of try and stop that and do a series of this breath stacking maneuver, and it really slows down your breathing, but also expands your lungs really nicely. So the benefits of breath stacking, it increases your lung compliance. So kind of how well your lungs expand, getting that air in them is called the lung compliance. And so it can help with that. It also increases your lung volume. So the amount of air that you're getting in your lungs, and it can improve airway clearance, which is how well your airways are able to maintain themselves, move stuff in and out of them nicely, which can help with a better muscle force when you're coughing. So I'm going to kind of demonstrate it if you can see me, but basically you take 3 or 4 small breaths on top of the other one without letting the previous breath out. When I get to the top, I'm going to hold it a few seconds, and then I'm going to let it out through my mouth really slowly over about 3 to 4 seconds. So I'll demonstrate it here if you can see me. So. And it just kind of helps get air in deeper than your normal breathing would get air into your lungs. So we always say to do 3 to 4 trials. So do what I just did 3 to 4 times, a few times a day. So or whenever you feel like you're getting anxious or you're short of breath, or whenever you think of it, basically. So a few breaths on top of each other. It really gets the air. The last couple breaths are really hard to get in, so do the best you can, but it gets the air deeper into your lungs than it normally otherwise would go. Hold it at the top just a few seconds, and then let it out kind of slowly. And then do that again 1 or 2 times, and it kind of really slows down your breathing nicely. And hopefully it would help with the shorter breath too, but it also kind of increase your lung volumes and help with coughing, getting that air in and out really nicely.
Guess not. Go ahead.
Oh, okay. Okay. So there's one more breathing exercise, and this one does involve, I was trying to get a picture, but I couldn't find a good one. It does involve a small device. And actually in our ALS clinic, the speech therapist hands these out, which seems kind of different because it is a breathing training, but it helps with your speech too. So it's kind of a 2-in-1 thing. It's called an expiratory muscle strength trainer. So an EMST, and it strengthens the muscles in the upper respiratory tract. So there's intercostal muscles, which are kind of like in your rib area. The submental muscles are underneath the chin here. Then there's the muscles inside that help move the vocal cords, and then the muscles of the pharynx, larynx, and soft palate kind of back there too. So it helps a whole bunch of muscles that assist with your breathing and your speaking. And so what it is, it's a little device. It's really maybe like a few inches long, and you breathe out, you exhale into it, and it releases a pressure while you're exhaling that makes it harder to exhale that air, which helps build up the strength of those muscles while you're exhaling. And so it comes with a thing, there's a piece at the end of it that you can turn, and so you can change the pressure on it. So if you want to start out at a low pressure to breathe against, you can, and then as you gradually, your muscles get better, you can move up to higher pressures. I think it goes from like 5 to 30. I actually don't know exactly, but there are different pressures that you can put it on. For as your muscles get stronger, you can increase the pressure and kind of strengthen them more that way. So it's not a resistance that you're breathing into, but it's more like a pressure that's coming back at you when you're breathing. Nothing too crazy, but it does, you can feel it. And so you have to try and breathe a little bit harder into that just to get the air out into that pressure. But it does, so it's, speech therapy uses them a lot because with the muscles that move the vocal cords, it can really help with that. But it'll also strengthen the muscles of your breathing. So the ones in your ribs and under your chin, and the ones that help you breathe in there. Okay, so that is the 2 main breathing exercises that we teach. So the next part I'm going to go into is supportive equipment that can help when you do just need a little more support with certain things. So the benefits of the supportive equipment is more energy. So if you're using some kind of non-invasive ventilator at night, it in turn gives you more energy during the day while you're awake because it lowers your work of breathing at night. Better sleep because you're not working so hard. Even if you don't feel it, just breathe while you sleep and it can make your sleep better. Feel more comfortable just by, some of them get secretions out or assist with your coughing, will just make you feel a little bit better. And they can help you think more clearly. It's all related up there. So The first one I have is a suction machine. There are different ones, but this is generally what it looks like. And they're usually some of them are portable, some of them are not portable. So it depends what kind you have, but you can take them with you. Usually they'll give you a bag that you can bring it with you. And a suction machine is kind of just like it says, I think, my next slide. Okay. So it removes mucus and saliva when your ability to swallow has been impaired. So if you notice that you have more saliva that stain in your mouth that your body would normally swallow without you thinking about it, it can help with things like that. But also if you just feel more congested, in general, it can remove mucus too, kind of from back in the throat. So it helps you breathe easier. It decreases choking with that saliva. You don't want it going down the wrong tube in the back, so it can suck that out. And it generally just make you feel more comfortable. So a home care company would come and set this up for you, show you how to use it. But it's kind of like at the dentist when they put that thing in your mouth that sucks out when they're cleaning. Kind of like that, but the tube that goes in your mouth is bigger than the one at the dentist. So it goes, let me go back to my picture. There's this tubing part and with the blue piece at the end, and the part that would actually go in your mouth attaches to that blue piece. You turn it on, it kind of sounds like maybe a small vacuum, and it really just sucks everything that's in your mouth and the back of your throat. It goes into this canister, I know kind of gross, but you can rinse it out easily. And it just helps remove things that you're otherwise unable to remove yourself.
Michelle, there is a question about if there are portable suction machines that are quieter than others.
Yeah,
Smiling.
I don't think so. They are loud, I know. Yeah, it's almost worse than a vacuum, I think, because I don't know, it's got this pumping noise that it does. But I have not, because a lot of people bring them in, and the ones from when I used to work inpatient in the hospital, I have not seen any that are quieter than any other ones. But it's a good question. I will ask, because I have just from mine's only by observation. I don't know for sure, but I have not seen any that are any quieter than any others that people bring in, unfortunately. They are loud. I agree. Okay. The next piece of supportive equipment I'm going to go over is the cough assist machine. If any of you have seen that. And so it basically does what it says. It assists your cough to make it stronger, to hopefully move stuff in and out of your airway that you otherwise would not be able to move yourself by coughing. And so this one is pretty typical. I think there are some different ones as well, but I think that's pretty typical of what it looks like. And so the machine has an on and off switch. Again, this one is also delivered by home care. Essentially, they should set the pressures for you and show you how to use it. I have had people come in and bring theirs into my clinic saying that it was just dropped off and not shown how to use, unfortunately. So I do show them how to use it if someone brings it in. So, but essentially home care should help you with that. And so you can either use it with a mouthpiece or a mask. This picture shows, I don't know if you can see it, it's kind of on the edge, but it has a mask on it. There is a mouthpiece attachment too. That only works if you can, kind of like our breathing test, if you can make a good seal around that mouthpiece. Otherwise, I think the mask is better. So the mask, either you or somebody else would hold up. It covers your nose and your mouth like a triangle. You would turn the machine on, and it with the mask on nice and tight around your face, it pushes air into your airway, usually over 1.5 seconds. There's a very and then it kind of pulls it out over 1.5 seconds as well. And then there's a small pause, and then it does it again, in and out, small pause, again, in and out, basically however long you have it on your mouth. So we would generally do about 3 to 5 cycles to really move what needs to be moved. And then sometimes the suction, once you do those cycles and there is something in your mouth, the suction can help get that out if you can't otherwise get out what's in there. But if you're, I think I have more. I should probably change my, okay, my screen. So it stimulates a natural cough by applying positive pressure to inflate your lungs, and then it uses a vacuum-like suction to pull everything back up. So about 1.5 seconds in that positive pressure, and then the vacuum-like suction 1.5 seconds out. And sometimes it is, I don't know if you've ever used one, people that are here, but it does, it sometimes moves your lips and your the vacuum-like suction that pulls it out is kind of strong. The home care people can put different setting, you know, if you try it out when they're there and you feel like it is way too strong, they can decrease the pressure a little bit to make it a little more comfortable. But it is supposed to help your coughing. If you cough, try to do a cough while it's in there, it will make it a little bit stronger. Sometimes that coordination is hard, so you don't have to do that, but it will mimic a cough, pushing the air in and out really fast to move stuff that you can't otherwise do. If you do need something like this, we say to use it regularly, like when you wake up in the morning, before you go to bed at night. Some people will do it before meals just to try and clear out before they eat, or as needed. If you feel like there's something in there that you can't move yourself, you can go ahead and use it. So each session typically lasts 5 to 10 minutes. So you do some like a 3 to 5 cycles of the air in and out with the pauses. See how you feel. If it brought up everything that you need to, you can end there. If you feel like it didn't, you can do again 3 to 5 cycles until you feel like it worked for you. I will say it's not for everybody. We do order it on people and they just really do not like it. Feel like it doesn't help them. So it's a good thing to try, but I will say the people I see, there are, I don't know a percentage, but there are some that just really don't like it and they send it back to the home care company. Totally fine. Whatever makes you comfortable is basically what I like. So the cough assist benefits, it helps keeps the lungs clear, reduces chance of infection by mucus that's kind of sitting in there that you can't move and then it gets infected. But it can also help strengthen the diaphragm, just getting your lungs moving in and out when you're not able to do so. Okay. So I think my last piece of equipment, but the biggest one, is non-invasive ventilatory support. So like a CPAP, BiPAP, something that you would wear at night, also during the day too, that lowers your work of breathing. It doesn't breathe for you, so you still have to breathe on your own, but it helps get the air in and out with each breath, to help to kind of lower your work of breathing, give you more energy, and just be able to get more air in and out of your lungs than you would be able to do on your own. So the one I have here pictured is a Trilogy. I would say that's our most ordered one from our clinic, but there's one called an Astral that we see a good amount. Those are probably our 2 biggest one, but there's other brands too. Can depend on your insurance, depend on what you need, what your doctor orders. But I would say the Trilogy is our most ordered one in our clinic. Okay. So non-invasive ventilatory support. So invasive ventilatory support is something that goes in you. So either you're intubated with an ET tube, or you have a tracheostomy going in and help you breathe. That's invasive. So this is non-invasive, which means it's all coming from the outside. It's not anything that actually goes into your body to help you breathe, if that makes sense. So the Trilogy is our most ordered one. And the setting, so there's a few different, let me just make sure I'm going with this. Okay. There's a few different settings That can be ordered, but what we call the AVAPs is our most recommended when you, like, if you were to see one of our pulmonary doctors, it's our most recommended setting on the machine. And AVAP stands for average volume assured pressure support. Kind of a lot of words. So we say AVAPs. And the machine gradually adjusts the air going in and out to match your current breathing patterns, to target the amount of volume of air that your body needs. So it adjusts breath to breath, and the machine can figure it out. It adjusts how much air that you're breathing in each, the volume of air breathing in each breath, based on what it feels like your body needs from how you're breathing. So a fixed volume of air is delivered, but the pressure changes to maintain that volume. So the doctor orders the amount of air that it wants you to breathe in with each breath. And it tries to deliver that amount of air with a different pressure based on how you're breathing to try to maintain that amount of air. I feel like it's very complicated, but it works really well to try and match how you're breathing to get that amount of air in you. There's a couple let me just go to my next screen. So I'm going to explain the difference between the CPAP setting, the BiPAP setting, and the AVAP setting. So the CPAP, I think, is the one that you would hear most about, used with sleep apnea, mainly, and it is a single, so it stands for continuous positive airway pressure. And it's a single pressure delivered into your airway. So the doctor would set that pressure and it does not change. So it just keeps cycling this air in and out based on this pressure that your doctor sets. And it's just one pressure, so it's only going in. And it just keeps doing that. It does not care what it thinks your body needs. It does work really well with sleep apnea, because sleep apnea, you stop breathing overnight, so this just keeps putting the air in and out. But for something like ALS, it's generally not as comfortable. Then there's the BiPAP, which is a little bit more support than the CPAP. It's bi-level positive airway pressure is what it stands for. And it delivers two pressures, one going in and one going out. And so the inhalation and the exhalation pressure. So the CPAP is only going in. The BiPAP is going in and out, but those pressures are set from your doctor and they do not change either. So it is a little bit more support than the CPAP, just because it's delivering those pressures in and out. But also it's not as comfortable because those pressures, it's just the pressure of air going in and out is not changing based on what your body needs. So the AVAPs, the volume is, the amount of air is delivered consistently but that pressure, how fast, how well that air is going in and out of you changes with each breath to match what should be more comfortable for you. So it's generally just a more comfortable way. It's really just meant to keep you comfortable. It's a very comfortable way of breathing. People that have used all of these these different supports, like in our clinic anyway, really like the AVAP setting. It works really well for them. I know our pulmonary doctors order that a lot. I guess I don't know in other areas how things are ordered. But it's a good thing to ask about if you're on one of the other ones and you want to try something different that might be more comfortable. I feel like that's very confusing, all that, but maybe I will. Let me just see what I have next.
I think that made sense.
Okay.
And I think AVAPs are pretty commonly ordered.
Okay. Yeah, I know we ordered a lot. I don't know how others, but hopefully it's being utilized well. Let me see what I have coming up. So the benefits to non-invasive, I know it's a scary thing to want to try. it's, I don't know, some of our patients have said it's almost like giving up on their breathing, things like that, but it really is supposed to help you. It's really a good thing. It's just going to make you more comfortable. So, I try and get people to use it before they even really need it. It rests your lung muscles. It lowers your work of breathing while you're using it. You're still breathing on your own. It's just doing some of that work for you to make you more comfortable. It provides more comfort while you're sleeping. People that are using it are usually able to sleep longer, better. And it will improve your fatigue and your breathing during the day, because at night you got more breathing rest. So these are an example of some of the masks that come with the machines. So I think the home care companies like you to start out on a full face mask. A lot of people will move on for those, but some people like those. The full face mask is on the left. It really covers, it's the triangle again, covers your nose and your mouth fully. And then with the headgear that goes around your head, and then the tubing attaches in the middle on the front, and which is how the air gets in and out. There is, let me see if I have this on a different slide. I don't want to go ahead of myself. There is, this one I know can be associated with some breakdown over like the bridge of your nose up here, kind of just irritate that area. If the full face mask is a good mask for you breathing wise, but it is irritating your skin around the area, there are barrier creams and also barrier like patches that you can put on or under it, so it does not irritate your skin. So there are some solutions with that, if that is a problem. The next one in the middle is the nasal pillows. I would say that's pretty popular from what I've seen. It basically just, it goes right into your nostril, so right into your nose. It does not cover the mouth at all. And it delivers that air just into your nose. So if you don't want something really on your face, the nasal pillows is a good option. The only problem is that if you're a mouth breather, and so you sleep unknowingly or knowingly with your mouth open at night, it is going to affect the pressure going in, because it has the air is going in a different way too. There is a chin strap option, which is actually on this patient or this model. I don't know if you can see it, but there's a thing that the fabric that's going underneath the chin, and it's trying to hold your mouth closed. It doesn't do it too tightly, so you can't open your mouth at all. We do have some people that use the chin strap option to keep their mouth closed while they're sleeping, if they like the nasal pillow option. And then the one on the right is called a nasal mask. So it's also not covering the mouth, but it's like a triangle just over the nose. There is, I think, another option that's kind of nasal pillows, and then it goes over the mouth as well. I don't have a picture of that one. There's a whole bunch of different options to find what works for you based on how you breathe. So I know the insurance companies or the home care companies, so they give you one, and I think they let you trade it out every so often to try to find one that works for you. So hopefully with that, you can find a good one that does help you be more comfortable while you use the machine. I guess that is it.
Oh, good. I'm gonna pause the recording for a minute.
The oxygen oxygen, it does come up a lot, and we typically find, so the amount of air is two separate things. So the oxygen in the air that you're breathing, 21% is in the air around you. It's all the same. And the amount of air that you're breathing in and out is kind of two separate things. So even if you're not getting air in and out as well as you used to, your body is still using that oxygen the same way that it always did. So we have, unless there's other underlying like respiratory issues, from what we've seen anyway, oxygenation is generally not a big problem with ALS. So you can check it on your finger with the pulse ox. If you have cold fingers, they don't work very well, just so you know. So it won't, if your fingers are cold, the blood flow isn't getting out there, and it can make the reading look lower than it normally would. So in our clinic, we have one that goes on your forehead that we check it in, just to make sure the fingers are accurate. But that is a good one. Generally, when we've done that, for most people, the number is really good. So the oxygenation does not seem to be too big of an issue with ALS unless there's other underlying conditions. So even if the air that you're getting in and out is not as great as it used to be, the oxygen is still there going through your body. We also can check it. I do this. This is more invasive, so they don't like to do this as much, but I do it if needed. We do what's called an arterial blood gas. I don't know if anybody's ever had one. They are painful. I apologize. But we do draw those. That's drawing blood from your artery, usually like where your pulse is in your wrist. There's an artery by the elbow that we can use too, but the blood in the artery has oxygen in it where the blood in the vein does not. So we go and get the blood from the artery, and it tells us the exact amount of oxygen in your blood, just in case they're questioning the number on the pulse ox. It also tells us how efficiently you're breathing. We get your carbon dioxide level from that breathing. So when you breathe in oxygen, you breathe out carbon dioxide. But if you're not breathing efficiently, you're holding on to too much carbon dioxide. And the machine, like the Trilogy, can actually help move that in and out like it should. So if they are questioning something about your breathing and how much carbon dioxide you're holding on to, we do that blood draw as well. So we can get those two levels really nice. But the oxygen, we haven't, a lot of our patients are not on oxygen. Their numbers, even if they're not breathing as well, their oxygenation, the oxygen that they're breathing in and their lungs are using that oxygen the same as it always has been. So we do have some that are on it, but they generally, I guess I don't know for sure, but have other issues, COPD, things like that, that are playing and going into effect too. So does that answer